and challenging issue for high-risk pregnancy specialists. It affects about 1 to 2% of all couples.
Thank you, Dr. Dina, for your nice induction of this session. And actually, we are very happy to see you again in this audience. So it's my privilege to let you know that there are two honorable chairpersons today. Respected Professor Ifatara Madam. She is the former professor of OBGYN at Dhaka Medical College and now currently working as a professor at Popular Medical College. And there is another respected chairs, Professor Raushan Morshed, professor of OBGYN at Chittagong Medical College, and she is the past president of OGSB in the Chittagong branch. I would like to request our honorable chairs, please come to the dais and ornament the session. Please, madam. Thank you, madam. And dear audience, you will be very happy to know that today, after this lunch break, I think you all become sleepy, but I am sure that our today's speaker, he will keep you awake by his excellent presentation. Now, I would like to request our legendary professor, Professor Mahesh Chulani. May I request, sir, please come to the dais and please. And actually, we are eagerly waiting for his presentation. And before he going to start his lecture, I would like to request Professor Ifatara Madam to say a few words on behalf of our speakers.
Good afternoon and a very warm welcome. It is my proud privilege to be able to introduce our learned speaker, Professor Mahesh Chulani. He is the Associate Professor, Senior Consultant, Division of Maternal Fetal Medicine, Department of OBGYN, National University Hospital, Singapore. He is also the Faculty Lecturer at the Yang Lu Lin Hospital of Medicine at the National University of Singapore. His special interest is in high-risk pregnancy care and fetal genetics. Now it is time for you. The floor is open. Professor Mahesh Chulani.
Need to change your... Fantastic, fantastic. Yep, thank you. Thank you, Madam Chairpersons, welcome everyone. Welcome back. So the moderators made my life a bit easier by saying that I'm going to entertain you and I'm going to keep you awake after lunch. I don't think that's going to happen because I had a heavy lunch and I'm quite sleepy myself. So, so these are my affiliations and declarations. I have no conflicts of interest to declare for this talk. And we heard earlier some discussion from Professor Biswas about the university and how it's doing. And some people approached me to ask me what is the setup that we have. So I'm just happy to announce to you that we are actually moving from the Department of Obstetrics and Gynecology to something called NUWOC, which is National University Center for Women and Children. And actually, we look after, in Singapore is a small island, and we look after the western sector of the island of 1.2 million people is under our responsibility. So this is the NUH, the National University Hospital many of you heard about or know about. But NUWOC includes now the Alexandra campus, and Ng Teng Fong campus, Jurong Medical campus, 7 polyclinics, and we broach into the community. So that's where we come from, Prof. Biswas and myself. Many of you are very familiar with all the faces over here. Prof. Arul was just online a little while ago. Prof. T.H. Chaudhary was here earlier. And I want to thank Professor Firoza Begum as well as Professor Tabassum Begum for inviting us here this time. I was very privileged to be here at the first conference, and I'm very happy to be here for the second conference. And I'll try to keep to time so they can invite me for the third conference. So these are some of the pictures that I'm sure many of you recognize many of the people in these pictures. So it's a great pleasure to be here and come and enjoy your food. I learned yesterday that it's not called Hilsa fish, it's called Elish. So I'm practicing. So let's talk about recurrent pregnancy loss. Now, we do know that pregnancy is the most common medical problem for reproductive age women. We also know that if you take 24 weeks as a threshold for viability, then anything that happens under 24 weeks, we call a miscarriage, and anything that happens after 24 weeks, we call it a stillbirth. The frequency, many of us are well aware in this audience that it's beyond 12 weeks, about 1% chance something will go wrong. Before 12 weeks, maybe 13% chance something will go wrong. But now I show you some interesting data. If it's below 6 weeks, 40% chance that something will go wrong. Okay, and if you look at actual getting pregnant, all conceptions, if you take all conceptions, implantation failure happens in 30% of the time. Preclinical failure 30% of the time. Clinical losses 10% of the time. And live birth is a rare event. So if you think about it, there's a lot of fetal loss that's happening. Most of us spend our time talking about the sporadic losses at 15%, but 2 losses can happen between 2 to 5%, and 3 losses about 1%. So every one of you in the audience is actually a miracle. And how does this miracle happen? Well, this miracle happens because at conception, a lot of things can go wrong. We can have chromosomal disorders, subchromosomal disorders, monogenic disorders. We can have, I can't read that, developmental disorders, and you will hear later about epigenetic disorders. But everything that happens to us during these first 9 months of our life actually dictates what's going to happen in the next 90 years of our life. And you heard earlier that I don't believe that all of us are in the business of pulling out babies, whether from the natural route or through the abdomen. We're not in the business of bringing out babies. We're in the business of shaping the future generation. So we need to bring out healthy babies, right? Now, 15% clinical pregnancy loss, 15% of the time, of which 2/3 happen in the first and early second trimester, and about 1/3 will happen later in gestation. If you look at the mathematics of this, 3 pregnancy losses was the typical description. You will hear from the panel later that there are groups that talk about starting investigations at 2 pregnancy losses, that's early losses, and possibly even after 1 late loss. But if you take the theoretical loss rate of 15%, if you have 3 losses, the theoretical loss rate is only 0.3. Actually, our loss rate is 1%. So something else is happening. It tells you there's a systemic failure in the system. So at a single loss, about 15%. If you have a second loss, goes up to 20%. You have a third loss, 30%. And you have 4 losses, 33%. So there's a systemic problem that is happening that we need to start finding out. And we don't know what it is. That's the reality of the matter. We don't know what it is. So the American Society talks about 2 or more failed losses. What is it? Well, half of the time, we don't know what it is, right? And because we don't know what it is, we are all doctors. We don't have the gumption to tell our patients we don't know. So we tell our patients it's an idiopathic loss, right? Because we're not prepared to tell the patient we don't know. But the reality, if you translate idiopathic to plain English, is we have no idea. So let's talk about the things that we do have ideas for. So we have there will be epidemiological factors. There'll be anatomical factors, endocrine, environmental, infection, and psychological factors, genetic factors, and coagulation and immunological disorders. Let's look at this. If we take just the age alone, as the mom gets older, both the miscarriage as well as stillbirth rate rises. Look at this. At 45, I recently delivered a mom who was 46. When she first came to me, I delivered her earlier babies. When she first came to me, she said, "What's my chances?" I said, "Well, I'm going to look after you, but I'm telling you now, you have a 93% chance it's not going to continue." And fortunately, she wasn't as a remaining 7%. But we have to be frank. We have to be honest with how we manage our patients. So if you look at the data is very clear. As the mom gets older, there's an increased risk of fetal loss. Now, what about the father? The father is equally at fault. So if you look at the moms, right? The mom's age, as the mom moves on, she moves from standard risk to high risk. But if you look at the dad, he also moves from standard risk to high risk. And the highest risk score happens when the mom is older and the dad is older. We normally will talk about an average. So the average is a 5.5 or 5.6-fold higher chance. But look at the upper limit of this average, almost a 10-fold higher chance. So let's be frank, okay? We don't want our families to start making babies when they're geriatric like me, right? We want them to start young. Okay, anatomical problems. So congenital malformations, we all know these. Fibroids, cervical incompetence, endometrial polyps, intrauterine adhesions. Endocrine disorders, very important, must be looked out for, all the way from diabetes, thyroid disease, PCO occasionally, and hyperprolactinemia, but mostly diabetes and thyroid disease. Infections, so there will be the usual infections, which is talk and not torch, because as Prof. Biswa said yesterday, the herpes part is more perinatal than fetal loss, Listeria treponema, some of the smaller microorganisms, as well as substance use and substance abuse. So these can be a problem. Now, genetic causes. Okay, most of us were trained that in genetic causes, about 3% or so will be some form of genetic cause, either a structural malformation, a chromosomal disorder, or single gene disorder. You've heard in this yesterday, and you will hear today about other genetic causes. But we also know that this is old data. If you look at the latest data by Ron Wapner, this number can easily double in the range of genetic disorders, right? But let's talk about the scope of genetic conditions. So if we take everything up to 24 weeks, the earlier we are, the losses happen, they tend to be cytogenetic. And as we move down, the cytogenetic component actually decreases. Types of cytogenetic conditions may be a trisomy 16, even if it's a confined placental mosaicism. Monosomy X, polyploidy, and then from the earlier it is, the more the 16s and the 6s play a role. The further it is, the more the 21, 13s, and 18s play a role. If it's only the first one, aneuploidy is quite common, but as you move from second and third one, the role of aneuploidy actually falls precipitously, which means that there must be something else that's playing a role. So if you look here, 50% in this row, and if you look at Joris's data, he says up to 70% if you look at array CGH, which means what? As you get from karyotyping to array CGH to sequencing, you will see more and more genetic abnormalities in the idiopathic range of the category. Of course, we have the translocations, whether they're reciprocal translocations or Robertsonian translocations, and how frequent are these, right? 5% of cases in one partner, there may be a balanced translocation. It's twice more likely in the mom than the dad. Reciprocal is twice more likely than Robertsonian, and you may get different types of mosaicism on the X chromosome. We mustn't forget the guy all the time. We have to keep remembering the fellow. The fellow has a role to play, even though it's very small. Okay, and sperm may have abnormalities as well. Okay, these are the range. We don't have to go through this slide. These are the range of single gene disorders that might play a role. But I will talk briefly now about certain types of single gene disorders that are going to gain prominence in the rest of this lecture. Okay, and these are the thrombophilias. But before we talk about thrombophilias, the story doesn't even start in the mother's blood. The story starts when from the egg, right? You can see here that a problem in the germ cell can lead to fetal loss. So this is CYP3 gene, right? This is CYP3 gene, and this is alters meiosis. How small are these abnormalities? If you look at this, this is one type of CYP3 gene abnormality. It's called an intronic deletion. It's a deletion, not even the exome. There's a deletion of the intron, right? So it's so hard to find, right? And yet you see if this cassette here, ACTT, if this cassette is removed and you go straight from A to G, because this cassette is removed and you go from A to G, you can have recurrent miscarriages, right? If you take this one, for example, you take this T, and this T is, in this genogram, this T is deleted and you get nothing up here. this happens at a junctional splice variant. If it happens here, again, you can get miscarriages. So a miscarriage can happen. We talked about idiopathic. How low do we go? And how low do we go? We go down to the single base pair. That's how low we go. All right. So, but that's on the female gamete. What about the male gamete? Well, the same problem happens with the male gamete. So mutations on the male gamete in the male can lead to azoospermia as well. So this particular issue is persistent. Now we talk about the simple ones, right? Thrombophilias and APS, antiphospholipid antibody syndrome. And these could be either inherited, right? For example, factor V Leiden, prothrombin gene, or could be acquired. And you have here the rare one. Well, they say rare, but it's quite common in the RPL population. And what is protein S and protein C? The way to think about protein S and protein C is to think of them as internal anticoagulants. Okay, they're endogenous anticoagulants. They keep the blood flowing through the system well. And remember, in the placenta, the vessels are very fine, especially early on. They're very, very fine, even before they become venous sinuses. So the blood must flow. And if they're sticky, they're going to plug. If they plug, you may not carry on with the pregnancy because oxygenation gets affected. So these are the common conditions: protein C, protein S deficiency, 83 deficiency, factor V Leiden. This one is controversial. I have to tell you, the MTHFR gene, there's controversy on it. But if it's a homozygous mutation, there may be homocystinemia, and it may be associated with RPL. And finally, prothrombin gene. I will try to keep the time. These are some new potential markers, as you can see, that's coming online. And you heard earlier in the earlier discussion the role of lupus anticoagulant and ACA. These become important in terms of recurrent miscarriages as well. So what about immune problems? Well, the placenta is actually an immune organ. It's an everything organ. The placenta is an everything organ, but it's an immune organ as well. And there are two parts I draw your attention to. One is these NK cells, natural killer cells. They need to be in balance. If they're running too hard and too fast, then they may affect. Remember the conceptus. Okay, the conceptus is 50% foreign DNA. Now, if I was to take a small bacteria and put it in your bloodstream, a tiny one, you will launch a massive immune response. You will not allow the bacteria to survive because your immune system comes into play. The uterus is a privileged organ, the placenta is a special organ, and the conceptus is 50% foreign DNA. And so things have to be in balance to allow 50% foreign DNA to survive and to live for 9 months before it comes out. If I take your partner's blood, a drop of your partner's blood, and not cross-match, put it into your bloodstream, you won't accept it. But you're prepared to accept a 50% foreign DNA. You need to put that in context. So the NK cell has a big role to play. So does Th1, Th2 cells, the balance of Th1 and Th2 cells. Now, if you look at Th1 and Th2 cells, in healthy pregnancy, the Th2 to Th1 ratio is like this. But when pregnancy, and we heard earlier we were talking about placentation, right? Anita was talking about placentation. If you look at placentation, the Th1, Th2 ratio is reversed. And this causes a problem for us. And what we do know is that progesterone tries to balance this. So when we talk about the role of progesterone, this is one of the mechanisms, there may be others, this is one of the mechanisms that progesterone may help in the immune system. And if we look at progesterone itself, or progestogens, the meta-analysis of 15 trials, 2,000 over patients, subgroup of 3 trials, women with recurrent spontaneous miscarriages, progesterone treatment is statistically significant decrease in miscarriage rate. We need to remember this data when we talk to our patients. Now, how do we move this forward? Okay, how do we move this forward? The other fact, so if we take the easy ones, environmental psychological issues, counseling is important, emotional support is very important. And of course, infection screen and treat as necessary based on what Prof. Biswas talked about yesterday. Anatomical factors, imaging technologies, whether it's ultrasound or MRI, and treat as necessary, which may be a surgical option. Endocrine factors, make the tests and manage the endocrine features, whether they be diabetes or thyroid disease. Coagulative disorders, inherited. We always come back to the same thing because we are OBGYNs, we don't have many drugs that we can use, no MAB type drugs. We use aspirin and low molecular weight heparin most of the time. It's just a matter of when we use it. Okay, and finally, we move on to something called IVIG. Now, I'm sure you've heard of IVIG. Before I go to IVIG, I just want to say that anti-TNF is not approved as yet. It is still a research phase. It is a harmful drug. I don't think we can use it just yet. We need to learn. And paternal allele vaccination, which is still going on in some countries in our region, is proven not to work. Proven not to work. So let's talk about IVIG. So if you look at IVIG for RPL, this is old data in 2001. If you have multiple miscarriages, the IVIG seems to end up with a higher pregnancy rate. But the data was uncertain. Repeatedly, people questioned this data. They said, we're not clear, we're not sure, it may work, may not work. So I show you the data that came out in August 2022. This is the data that came out in August 2022. All right, this is published in the Lancet, and you find that in the placebos, you'll find that this is the Kaplan-Meier data, and if you look at IVIG, this is the Kaplan-Meier data. So it is clearly statistically beneficial for multiple losses, provided there are multiple losses, 4 losses or more. And so genetic factors, well, of course, there's counseling. We could, of course, do various types of parental testing, whether it's karyotype, CMA, or low-pass sequencing. We could do molecular testing. There are people in the audience who know more about this than me. Counseling, sperm and oocyte donation. We must always have reproductive options. We must always share with the patient, not always throw technology at the patient. The patient may decide to have a sperm donation, oocyte donation. But of course, if those are not acceptable, then we have things like pre-implantation genetic testing, either for Mendelian disorders, structural variations, or aneuploidy. So that's possible. And finally, we could go a bit further. With technology, we can even go further. What about mitochondrial transfer if there's mitochondrial associated disease? So this was the monkey, the very first monkey. The title was Monkey Magic. This rhesus macaque was created using a nuclear DNA of one mother and mitochondrial DNA of another. So this was the very first time we knew that we could do it. And of course, not long after that, UK allowed it in some circumstances. So that's a whirlwind tour of RPL. I'm sure through the panel discussions, we have a great opportunity to discuss this a bit more. Before I end, I'd just like to invite you all to Edinburgh in 2023 June, where we have the ISPD. And also, for those of you who might be interested, our department is 100 years old, and we'll be having a centenary celebration around the 8th and 9th of October. And it's a hybrid session. If the session's of interest to you, you can log in and listen to it. And of course, the ever-eminent Professor Aru Kumaran, he has actually launched a scholarship in Singapore for global women's health. And we would invite people who are interested to come to Singapore, spend 1 year with us to learn about how to do research related to global women's health under the Aru Kumaran Scholarship. With that, I thank you, and I'm sure the panel will take over from here. Thank you.
Thank you very much, sir, for your nice, fascinating deliberation. Now I would like to request Professor Roshan Murshid Madam to comment on our speaker's lecture.
Thank you very much, Professor Mahesh Chulani, for his brilliant presentation. He has very rightly focused on the etiology as well as the management of recurrent pregnancy loss. Recurrent pregnancy loss is not a tragedy to the couple, but it is a disaster and challenging condition for the obstetrician also. In our clinical practice, we usually observe the couple with recurrent pregnancy loss. They are very much frustrated and they don't think for a live birth baby. But with the advent of so many technologies by which we can identify the cause and we can treat the cause, but still we are very sorry that 50% of the cases are idiopathic. Among the causes, the antiphospholipid antibody syndrome, anatomical defects of the uterus, infections, thrombophilias, these all are treatable conditions and the outcome is not that bad. But when there is genetic factors in the form of single gene disorder or in the form of structural abnormality of the chromosomes like translocation, deletion, or in the form of abnormality in the number of the chromosome like trisomy 21, trisomy 18, 13, the outcome is not that good because in these cases we usually go for parental karyotyping, but still it is only recognized by ISHRE. The other RCG or ACOG, they're not want to do the parental karyotyping in all cases. And the result is not that promising. And what to do? We have to counsel the patient for adoption or for oocyte donation or sperm donation. Prior to that, we can have a pre-conceptional counseling for the benefit of the future mental condition of the couple, because a good counseling can console a couple that without a child of their own, they can have a very happy family life. So I again thanks Professor Mahesh Chulani for his very brilliant and excellent presentation. Thank you.
Thank you so much, madam. Now, this is the time for panel discussion, and I'm very excited to call upon our 6 panelists today, and they are the legend in their field, and you all will be very happy to know their name. So, first of all, I would like to request our legendary professor, Professor Muhammad Rashida Begum, madam. She is the Chief Consultant in Infertility Care and Research Center and Vice President of OGSB. Madam, please come. OGSB Dhaka Division. Then our next panelist, respected Professor Munira Ferdowsi. Madam. Munira Ferdowsi, she is the head of the department, Shahid Sordi Medical College, which is a very renowned medical college in Bangladesh. And our very dynamic mentors, Professor Sheherin Farhad Siddiqui. She is the head of the department, Anwar Khan Modern Medical College. Our next panelist, our respected Professor Shahi Farzana Tasmin. She is the Professor of OBGYN at Rangpur Medical College and Vice President of OGSB outside Dhaka. Madam, please. We have another 2 panelists who are very well known in our country. Our lovely, brilliant Dr. Tanzim Sabina Chaudhary, Associate Professor OBGYN at Ibrahim Medical College, Bardem Hospital, and our most potential Dr. Tazmira Sultana, Assistant Professor, Dhaka Medical College, Feto-Maternal Unit. And actually, I'm very glad to inform you all that this panel discussion will going to moderate by one of the renowned Dr. Pratima Radhakrishna. She is the Director and Consultant of Fetal Medicine at Bangalore. Please come. And I hope you all will enjoy this panel discussion. And I'd like to request all the panelists, you should you're on time. That is 4 minutes allocated for each of you. Thank you so much.
Okay, a very good afternoon to everybody. Thank you very much, Professor Firoza and Professor Tabassum, for inviting me and many of my friends whom I'm meeting in India, in Bangladesh after the 2.5 years of COVID, and we have not seen each other for such a long time. So it's a nice, pleasant get-together as well for us. And I was very delighted to meet my panelists, well known in their field and well renowned, as I could hear the applause as they were walking up the stage, to discuss on the recurrent pregnancy loss. Now, what you're going to hear in the next 35 to 40 minutes is a lot of what already Dr. Mahesh Chulani has already elucidated to, but something that you can identify with your own country and your own practice is what we are trying to do, because it's okay that the practices in India is so and so, it's okay that practice in Singapore is so and so, the UK, US, etc. But how you practice medicine, and particularly this particular condition in Bangladesh, I think your professors are the best ones to tell you about it and how it, we can follow guidelines. So largely the talk is divided into the definition, the etiology, the valuation, the management, and the prognosis. And we all know that recurrent pregnancy loss is a very traumatic experience for the parents. It's very frustrating. Many times, in spite of doing investigations, we don't find the cause. And there is very little evidence-based diagnostic and treatment strategies. And of course, because there are so many studies, small and big studies, there are methodological weaknesses in that itself. So just to make my job easier, I have put down the names of my panelists on the slide itself, so they will themselves take the take you through the slide. And very importantly, there are so many different ideas about what exactly is a recurrent pregnancy loss. So Professor Rashida, so could you just tell us, how would you define a recurrent pregnancy loss?
Thank you very much for your question.
Louder.
Actually, previously it was called that 3 consecutive pregnancy loss is called a recurrent pregnancy loss, where ISHRE declared that 3 pregnancy loss is considered for general people, but for infertile patients, 2 consecutive loss should be considered as recurrent pregnancy loss. But in last guideline, ISHRE also considered that for all people, 2 consecutive clinical pregnancy loss are considered as recurrent pregnancy loss. But 3 consecutive pregnancy loss, which included both clinical pregnancy and biochemical pregnancy, can be considered as recurrent pregnancy loss. This biochemical pregnancy, until and unless it is proved at ectopic pregnancy, that is pregnancy is unknown location, it also can be included within these 3 pregnancy loss.
So essentially, ectopic pregnancy and molar pregnancy is not part of the definition. However, we see that the negative impact, the parents are as distressed when they have a ectopic pregnancy, as you all know as well. Now further on, recurrent pregnancy loss is divided into primary and secondary. Primary, if you've never carried a baby beyond 24 weeks, and secondary, if they've had interspersed a previous live birth, and then they had 3 pregnancy losses. Now, if they've had some miscarriage, 1 or 2 miscarriages, then they had a live birth, and then they had a couple more miscarriages. Although technically they still have had 4 miscarriages, but that is not counted as recurrent pregnancy loss because they have had to have consecutive pregnancy losses. So that is important. Now, we've already seen this when you look at less than 10 weeks, about 15% of pregnancies are lost. 2 pregnancy losses is seen in about 2%, but when there are 3 pregnancy losses, it's about 1%, which is slightly higher than chance alone. And as the maternal age increases, the chances of having a pregnancy loss also increases. And as the gestational age increases, the chances of losing that pregnancy reduces. Now, one of the very frequent questions that we are asked by our patients is, when they've had a pregnancy loss, what are the causes? Will it happen again? Now, obviously, the recurrence chance you know only if you know the cause. And the causes are, of course, many. And we already know that in about half of them, if you diligently go around looking for it, then you might discover a cause in half of them. But we all know in practical situation that's not always the case, particularly in low resource setting. So Professor Munira, so let's take each cause on its own and see how important it is as a causative. So uterine factors.
Assalamu alaikum and a good evening. I would express my heartiest thanks to the Maternal Fetal Medicine Society of Bangladesh for giving me the opportunity being a panelist in this session. And thank you, Pratima, for your nice question. You said that uterine anomalies, what are the uterine anomalies and what are the causes of this? We know that acquired and congenital abnormalities of uterine abnormalities are responsible for the 10 to 15% of recurrent pregnancy loss, and congenital abnormalities among the patients who are recurrent pregnancy loss are 10 to 15% are responsible for the recurrent pregnancy loss versus the 7% of all women.
We need to have a slide up there, please. Can we have the slides here? Thank you.
Pregnancy loss may be related to the impaired implantation, abnormal placentation, and septate uterus, and it is about the 16% of the loss of the recurrent pregnancy loss is 16% due to the septate uterus. And we know that in this case, septate uterus, there are poor blood supply and poor implantation is the important cause, and septate uterus is the important cause for the recurrent pregnancy loss.
Yeah, that's because the blood supply on the septate part of the uterus is very poor, understandably, because it's an anomalous thing. What about fibroids? Because many times the poor fibroids are blamed. Does it matter where the fibroid is?
Yes. Submucous leiomyoma is the responsible for the recurrent pregnancy loss because it protruded into the endometrium and it impaired the implantation of the fertilized ovum.
But fibroids anywhere else really don't matter.
There is no association between any other fibroids.
Yeah. So adenomyosis?
Adenomyosis, it has controversial role. Sometimes it may be the causes for the pregnancy loss.
But again, laparoscopy has not shown to be useful in these women. Endometrial polyps, we see it very frequently in women, don't we?
But there is no supportive data among the endometrial polyp.
Intrauterine adhesions now getting more and more frequent because the more DNCs that we do, intrauterine adhesions we cause.
Intrauterine adhesion, it is the important cause because the insufficient endometrium to support the fetoplacental growth, and same situation that the abnormal implantation and abnormal blood supply.
And then we come to my favorite, cervical insufficiency, mid-trimester pregnancy losses.
It is a very important factor for the mid-trimester abortion. So how could we understand that this is the case for the cervical insufficiency? I think that proper history taking is the very important factor for diagnosis of the cervical insufficiency, and the ultrasonography to see the cervical length. It is the important factor to know if their cervix is short or not.
And very typically, it is the painless dilatation and no pain at all, and the mother literally, when like how Professor Kipra says, she's just walking down the road and just the baby falls out. So that is typical cervical incompetence. And then the role of cervical cerclage and progesterone, we'll come to it in a bit. And ultrasound, of course, is very good. A transvaginal ultrasound is very good in detecting the short cervix. So these are simple measures that can be employed to check out the reason for causes. So with that, we move on to the immunological factors, which is probably some of the favorites of most obstetricians, I would think. Yeah. Go on, Professor Seri.
Okay. Thank you very much. Is it audible to you? Thank you very much for the excellent part of this, the criteria of the recurrent pregnancy loss. Actually, immunological factor, if you consider, that means the pregnancy. So whenever pregnancy means the baby has to grow in the inside uteri, and for that, the placenta circulation is very much essential. So whenever the baby is is a factor it may causes the immunostimulants as well. So if the patient cannot actually recognize that part, in that case, it may causes the immunological problem, which may interfere the placenta circulation. And this circulation means we need the placenta circulation. For that, the placenta perforation is required. So whenever there is immunological factor, it may causes the thrombosis. This thrombus may causes the actually formation of the clot, and ultimately it hampers the placenta circulation, and which may end result, it might be causes the early pregnancy loss, it may causes the late pregnancy loss, it may causes the placental insufficiency, which may lead to intrauterine growth retardation, even abruption.
So primarily it causes loss by causing thrombosis of the placenta.
Yes.
So, but there is a specific criteria to diagnose antiphospholipid syndrome.
Yeah.
So there are clinical criteria and there are laboratory criteria. Could you just make sure that we make the diagnosis of APLA correctly?
Yeah.
Because this is the woman who is going to very likely be treated with expensive medications.
Definitely, definitely.
Yes.
There must be some clinical criteria and as well as the investigation as well. So clinical criteria, if the patient has got the thrombotic, diagnosed thrombotic phenomena, it might be the thrombosis elsewhere in the body, 1 or 2 times. She may complain of even the cerebral vascular thrombosis or the VTE. Whatever may be the reason, it might be the causes where we can think about the immunological disorder or the thrombotic disorder. At the same time, it may relate to the pregnancy. That means if the patient has got the pregnancy loss 3 or more prior to 10 weeks pregnancy, or any date after 10 weeks, or any time, the patient may have got the single time date after 10 weeks of pregnancy. Even patient may suffer live birth, but has got the placental insufficiency, which may endeavor ultimately the formation of the abduction placentae or the preterm labor or the hypertension as well. Yes. Or the intrauterine death, which may ultimately we should go for the follow evaluation.
So in this context of recurrent pregnancy loss, she has already fulfilled a clinical criteria because she's already had 3 pregnancy losses. And the laboratory criteria also becomes very important because then you have to have lupus, anticardiolipin antibody, anti-beta-2 glycoprotein, or on 2 occasions 12 hours apart. Now that makes the test more expensive.
Definitely so.
So
but
that adds to the cost.
One thing we are considering, whenever sometimes we are finding that the antibody is positive, it doesn't mean it is positive. We'll have to take 2 tests 12 weeks apart. Yeah.
That adds to the cost is what I'm saying. So that's why we are struggling to kind of see whether if you have a good history, and maybe 1 set of tests, is it acceptable to call it APLA and then treat them rather than repeating these tests, because these tests go and 3 zeros, isn't it? Thousands, 30,000, 40,000, and to repeat it and it becomes
one
tricky.
thing we should consider that this thrombophilia, again, it might be the primary and the secondary. Secondary may be associated with the immunological factor as well. Whenever these factors are positive, in that case, they may secondarily form the thrombophilia. And this is why, though it is not actually, there is no evidence, but definitely we should consider about the thrombophilic screening for those patients who was having the not only the first trimester, but second trimester.
Second and third trimester particularly, and especially signs of placental insufficiency.
Yes.
Okay. So with that, we move on to thrombophilias and other fibrinolytic factors, because there are very few of them which have actually been implicated, because majority of the inherited thrombophilia have not been established as cause, especially in the first trimester. So factor V Leiden, prothrombin, protein S, and factor 12 deficiencies have do significantly increase. So with that, we move on to endocrine factors. Dr. Tanji.
Thank you. Thank you to the moderator and the scientific society of this conference. I'm very happy that you have given me endocrine factors, because I work in a diabetic hospital. And I think diabetes mellitus is one of the most important causes of repeated pregnancy loss, and which is also preventable. If we can make the patient conscious that having a good glycemic control at the time of organogenesis can reduce the risk of repeated pregnancy loss. So hemoglobin A1C plays an important role to find out whether the patient is having good glycemic control at the time of pregnancy. Second important factor, which we almost always forget, is polycystic ovarian syndrome. We always actually relate polycystic ovarian syndrome with infertility, but we forget the amount of first trimester miscarriage we get to see if a patient has polycystic ovarian syndrome.
Do you frequently see PCOS?
Yes, we do. Even after the patient gets pregnant, we get to see a lot of pregnancy loss in first trimester in case of PCOS. And should we use metformin? That's a different issue. Third is thyroid antibody and disease. Now, there has been controversy. Some of the guidelines before said that there was no need for doing routine screening of thyroid function in case of repeated pregnancy loss. Now things have changed. Like the last ESHRE guideline says that there is a chance of repeated pregnancy loss even after subclinical hypothyroidism with TPO positive. Yes. So nowadays, thyroid function test is recommended along with antibody.
In fact, in India, we see half of them have got thyroid dysfunction.
Without any symptom.
Pregnancy. They discover it in pregnancy.
Yeah,
so very frequent.
I think there is a need for thyroid screening now for those women with repeated pregnancy loss. Hyperprolactinemia is another cause, but we have to also know how to do the test for hyperprolactinemia. Like, I think it's wrongly diagnosed more because whenever there's a slight increase in prolactin level, we tell hyperprolactinemia. So it's very important that we repeat the test and also when to do the test. Early morning, it can be very high after exercise and stress. So to diagnose hyperprolactinemia, we have to have a proper test. And if it is positive, bromocriptine should be used. And last, I think, is the most controversial one, because luteal phase defect, till now, there is no clinically reproducible test to find out luteal phase defect. So the evidence is very poor about giving progesterone for the treatment of luteal phase defect.
Great. So with that, we move on to the genetic factors. So, yes.
It's me.
Professor Shahi, yeah.
Thank you. Am I audible?
Yes, yes.
Thank you very much
There
for your
is an
question.
echo in the room. But
thank you, Maternal Fetal Medicine Society of Bangladesh, for giving me the opportunity here. Regarding genetic factors, first of all, I have to say that chromosomal abnormalities of the conceptus is a recognized cause of sporadic and recurrent pregnancy loss. So that there are so many chromosomal abnormalities like structural or numerical, like aneuploidy, monogyny, trisomy, and translocation, deletion, and mosaicism, so on and so on. And there might be some single gene defect, polygenic, and multifactorial disorder also. Regarding balanced translocation, I have to say that sometimes patients are phenotypically normal, but for this reason, they can produce recurrent pregnancy loss or multiple congenital malformation or intrauterine death also.
So the parents themselves will be normal, but they could be carrying that. But again, the percentages or the incidence will come only if we diligently check all of them. So in a particular group of people, are they more likely to have an abnormal karyotype?
Particular group, they have, if the patient is young and she has recurrent pregnancy loss, if there is miscarriage, 3 or more miscarriage, and if there is family history, and if there is recurrent pregnancy loss in siblings or her family.
So the family history also can sometimes indicate the mother, sister, sibling, anybody. There's more miscarriages in that family could indicate that there is a defective gene circulating in the family that could be causative for the miscarriage. So in that group of people, you know, if you have to choose, then I think you need to choose wisely. But also remember that it is not always the abnormal karyotype only that is responsible. So again, when we start investigating, we should not get secluded to only one part of it and just ignore everything else. So there are a whole number of other environmental chemical stresses, etc., but there is no really high quality evidence, and there are whole bunches of other gases and enzymes and which have been implicated, but they're usually the sporadic spontaneous losses. So we will not go in that. Dr. Tajpira, are you here? Because I didn't see you in the afternoon. So there are many other factors. If you could just take us through that, what do you think would be important there?
Thank you, Dr. Pratima. The other factors, like I would like to say that BMI of the patient is one of the most important factors that can play a role in the RPL. There is a relationship that BMI is, if it is very much low, like 17 or 18, or high, like 25 or more.
So very low BMI and very high
they are
BMI.
associated with the recurrent pregnancy loss.
Yes.
And another factor is small but important, that the habit of the patient, like smoking, drinking, tea,
But you don't
coffee.
see much smoking here, do you? No.
Nowadays, so many women are smoking on the street or anywhere.
Okay, but
We
probably
see.
passive smoking?
Passive smoking is also important because they are more harmful than
They're more
active
harmful
smoking.
because they only inhale it.
Yes, yes.
There's no exhalation at
So
all.
we have to exclude this one, and also the some factor.
And we can always
It
blame
is
the mother.
sperm.
There are some male factors also.
Some sperm fragmentation or some other abnormality of the sperm, though it is actually related with fertility, but sometimes it causes
abnormal
recurrent pregnancy losses.
Losses can also occur with the male. Infection, listeria, toxoplasmosis, but they're really not causes for recurrent pregnancy losses.
Yes,
they may call
yes.
one pregnancy loss.
They
Like
can cause
trimester
one
and many-
pregnancy loss infection, but
and many of
recurrent
them will be
pregnancy-
associated with the
yes.
fetal abnormality also. You can see hyperechogenic bowel or severe growth restriction or severe oligoamnios and ventriculomegaly, and those can be signs of infection as well. So it is not a cause for recurrent pregnancy loss. Now, what do you think about exercise? If somebody is exercising, do you tell them not to exercise if they've had recurrent pregnancy loss?
Actually, it is not true, because exercise is a habit also. One who is used to exercise, she will not be
Increased
be
risk.
affected. Yes.
So exercising is good.
Exercising good.
Exercising is good. So we
Good,
should
good.
not stop women
Should
from
not
exercising.
stop exercise.
Yes. And if they have been
Continue
doing that
exercise.
all the time,
Yes,
like
yes.
they're marathon runners, they're swimmers, they are, doing exercises regularly, yoga enthusiasts, they can carry on doing all that. So with that, we move into the evaluation of the pregnancy. So Professor Rashida, could you say who are the women that you will start investigating and when?
Actually, when patient comes with history of recurrent pregnancy loss, that is consecutive 2 losses of clinical pregnancy, then we should start investigation.
And you mentioned IVF pregnancies. Probably there is a lower threshold to investigate the IVF pregnancies sooner rather than later, right?
No, IVF pregnancy, which investigations they need, we should do that. But for recurrent pregnancy loss, every patient is important, not
Yes,
only IVF
not
patient.
just the IVF, but
Not
IVF
only
are
IVF
more
patient.
hyper, I guess.
Even I consider all patients same.
Yes,
This recurrent pregnancy loss, we deal with same importance as IVF pregnancy.
So now the guideline is that evaluation and treatment after 2 consecutive losses. So again, I'm not going to go through this. It's very important to take a detailed history about when the loss occurred, what exactly happened, whether there's history of instrumentation, because we heard that intrauterine adhesions and all that also could cause good menstrual history, to look for endocrinological problems, looking for possibility or clues or markers for congenital or karyotypic anomalies in the family, consanguinity, environmental toxins, venous arterial thrombosis, etc., etc. So history is very, very important. Then you do a good physical examination, and don't forget the mental examination, because it is well known that depression and severe stress is significantly increased in couples who have pregnancy losses. So again, we can divide them as the most useful tests. Where are the tests that you're going to start when a woman has had a pregnancy loss? So the first test that actually needs to be conducted would be from where? Professor Shai.
As recurrent pregnancy loss is a very stressful condition, and more loss will put more and more stress to the patient. So first of all, counseling is very, very important. When a patient comes to us with a history of RPL, we have to counsel we have to counsel the patient regarding the different aspects of the outcome of the patient. Then we'll go for genetic analysis like amniocentesis and CVS. And if the baby is affected, then we'll offer termination. And we can go for IVF with PGT.
No, I'm saying when she's already had 3 miscarriages, at least the 3rd miscarriage, we have to check the products of conception.
Okay.
Because that's the first clue that you're going to get.
Sorry, ma'am, I didn't understand.
Sorry.
So first of all, when the patient comes, we should not straightforward go to parental karyotyping. First of all, we have to go for karyotyping of the conceptus. If it is positive, then we can go for parental karyotype.
Yeah,
and
so
if it is normal, then we can think another causes like maternal factors, and for the we can do for chromosomal arrays, microarrays.
Is array available in Bangladesh? Not yet.
Not available.
So that is something that people should get to know that it is available, and then I think it happens in all our developing countries that
not available
we don't know about it. It is very widely available. In India also it starts, then the pressure of the doctors builds on the genetic laboratories, and they start bringing those tests to your country. Initially they start high cost, then the more people are doing it, the cost of it comes down. That's exactly what is the story of NIPT, that's the story of array as well. The more number of people who do these tests, automatically the costs come down, right? So first the products of conception, and then you do the parental depending upon the products of conception. So that's a systematic way of going through it. Then how would you evaluate for the anatomical causes? Professor Munira?
Thank you. At first, we should do the uterine assessment.
It's not working.
We do the uterine assessment by doing ultrasonography and do hysterosalpingography, sonosalpingography. We should do this, and by this way we can determine that whether there is any abnormalities or not.
Yeah, I think ultrasound and sonohysterography is good. If you're doing hysteroscopy, you can do your adhesions, adhesionolysis at the same time. If there is septate uterus, then you can remove the septate at the same time as you're doing your hysteroscopy. Yes. So it's important to look for those. And how about APLA? I think we did talk about it a bit.
Okay.
So investigation for APLA.
Okay, thank you very much. Actually, we are always following the guidelines of the different especially the ASHRAE guideline, and they're very clear-cut. They mention that. So whenever one patient is having the 2 or more consecutive pregnancy loss, in that case, we will have to think about the thrombophilic disorder as well as the APLA, definitely. So for the APLA, we are doing the antiphospholipid antibody, anticardiolipid antibody, and lupus anticoagulants. And it has to be done 2 times, 12 weeks interval, and if it is positive in that case, we'll have to start the treatment. At the same time, I've already mentioned that APLA actually causes the failure in the first trimester, but the second and third trimester, we should consider about the thrombophilia as well. So for the actually diagnostic, we can extend the investigation further. In that case, we can extend it up to protein C, protein S deficiency, although it is not recovered properly, but we can think about that also.
The treatment is expensive, that's the problem.
Yes, but we are doing this thing and we are finding so many cases of protein C and protein S deficiency. We are finding, we are treating, and the outcome become very good.
Okay. So with that, we move on to the endocrinological thyroid function. Would you treat thyroid?
Thank you. It's working.
Yes.
Okay. Regarding thyroid function, as I said before, the earlier guidelines used to say that screening should not be done routinely, and it should be done only in those patients who have clinical manifestations of thyroid or disease. Also, they already have thyroid disease. But nowadays, it has been seen that even there is increased risk of miscarriage if the patient has subclinical hypothyroidism. Also, those women who are euthyroid apparently, but also have antibody positive. So nowadays it's saying that these women, even though they are euthyroid, they need thyroxine, levothyroxine for raised antibody. So nowadays thyroid function is actually recommended for repeated pregnancy loss.
Yeah. So you replace the thyroid and that will actually reduce the risk of miscarriage also. It's not just about diagnosing the thyroid dysfunction, because the treatment is also very important. And of course there are a whole bunch of other things which you will depending upon the individual case-to-case basis, you will decide whether you want to do these tests or not, like screening for diabetes, culture serology, hypercoagulable state, etc., etc. But progesterone levels, endometrial biopsies are not recommended and they don't really help very much. So I think male factor you did say, but would you do a male karyotyping? How willing are men agreeable to do karyotyping in these cases?
Sorry.
Are men readily accepting to do tests on them for recurrent pregnancy losses?
I can understand.
Do
Karyotyping.
men agree readily to do tests on them?
Oh no, the usual scenario is that they don't agree.
Yeah. So we should actually encourage them to do it, because it's
Yeah.
not always the woman's fault. The men also,
Yeah.
both in terms of fertility and for pregnancy losses as well. So coming to the management part of it now, the prognosis for a successful pregnancy, even after having 3-4 miscarriages, is generally good, irrespective of the cause. So when we find a abnormal parental karyotype, right? So what would you do if you find an abnormal karyotype report?
Okay.
And I presume it's more likely it's the woman who's got an
Yes.
abnormal karyotype, because the man you have not done only.
One of the parents may be affected by abnormal karyotype. Well, when we see there is an abnormal karyotype parental, then counseling is the most important part, because they get so much stressed. So to reduce the stress of the patient, counseling plays an important role. So we should discuss regarding different aspects of the outcome and the fate of this. And if the patient get pregnant, then we will offer her amniocentesis or chorionic villus sampling to detect congenital malformation or any other abnormalities in this fetus. And if the fetus become affected, then we should offer termination.
Yeah.
And for future pregnancy, in our perspective, we can offer IVF with PGD, which is not available in our country, but we can provide.
Do you do
And
CVS and amniocentesis here?
Yeah,
You do CVS
routinely.
and amniocentesis. Okay. So
And
that's good.
in our country, we can offer adoption, as there is no surrogacy or donation is not allowed in our country.
Yeah.
So in this way, we can treat the patient.
Good.
Thank you.
Okay. So and adoption is a good thing always. What about for uterine abnormalities? Where would you do a surgery? Where would you consider doing surgery? Can we have the slides back, please? Slides. Thank you. You can see me here. You don't need to see me there, isn't it? Yeah.
Thank you. You know that the septum uterus, septate uterus, it is the recurrent, it is the important cause for recurrent pregnancy loss, and you know that the infantile survival rate is 6 to 28% in untreated septate uterus. So, and 60% is the miscarriage. So that
when you
treatment
find
is
something-
essential. Hysteroscopic resection for septate uterus is required.
Okay. And so when you find something, you treat it, and these are the conditions where you find it and you can treat it and you can have a good outcome.
Yes.
That is the whole idea of screening. A screening is a condition that is picked up, can be treated, and then you have a good outcome. So I think that falls in place well. And of course, then the treatment for medical conditions. Dr. Tanzi?
Thank you. There are many medical problems, and actually the treatment depends on the medical condition causing the repeated pregnancy loss. Like if you talk about aspirin and heparin, we see that if a patient is suffering from APLA, there is definitely a role for heparin and aspirin in the treatment of APLA. And then there is diabetes, as I said before, it should be treated. Those women who are trying for pregnancy should start on insulin. If they are already on metformin, should they continue the metformin is controversial. And the use of metformin in polycystic ovary to reduce the LH and the insulin resistance is also controversial. Some people advocate metformin, some don't. Thyroid dysfunction should be treated definitely, and if it is a case of subclinical hypothyroidism with raised antibody, they should also start levothyroxine. And hyperprolactinemia should be treated with bromocriptine.
Okay. So then comes the big bunch of unexplained RPL. That is, we said it's almost 50%. So how would you manage these pregnancies, Professor Rashida? This is the challenge.
It is very difficult because debate has been going on for last 50 to 60 years, but solution has not come up yet. Still, progesterone has got some role, though PRISM study, a big study of UK and Netherlands, which shows that there is no role of progesterone in managing unexplained infertility. But progesterone has got some role in early pregnancy. The inflammatory cytokines, Th1 is essential for invasion, but very quickly it has to be shifted to anti-inflammatory Th2. So progesterone is responsible for synthesis of this, for upregulation of Th2 and downregulation of Th1. So progesterone blocking inhibitory factor, a protein which is produced by progesterone. But average amount of progesterone is enough for this. So if we can measure the progesterone level, and it has been shown that progesterone level in fetal-maternal interface was low in case of recurrent pregnancy loss. So progesterone level should be optimum. 12.6 nanogram per ml progesterone, and which should be increased 15% by 48 hours. It is the minimum requirement. So if progesterone level is lower than that, then we can add progesterone. So but it is very difficult to measure progesterone. It needs 3 readings per day. There is very variation of morning, evening value.
You can see Professor Mahesh shaking his head on progesterone. There is a pro-progesterone and there is an anti-progesterone group in this entire thing in terms of recurrent pregnancy losses, isn't it?
I'm not against progesterone. Sorry. No, never finish first.
So it can be used if we can measure progesterone.
Yeah, well, that's the problem, isn't it? Measuring progesterone also has not been correlated to the risk of loss. So how much progesterone is good amount of progesterone?
It is told that 12.6 minimum, they can 12.6 nanogram per ml.
So you're talking about luteal phase deficiency progesterone, is it?
No, not luteal phase deficiency, just early pregnancy.
Can we hear your thoughts? Because you've been shaking your head really vigorously now.
Sorry. I apologize. Yeah, I'm shaking my head because we have to be honest. And I said we have to be honest. If it's unexplained, we don't know what it is, science doesn't know what it is, then what are we treating? Let's not bluff us. I mean, yes, it's fine to treat the patient, to treat ourselves, make ourselves feel happy. That's fine. Okay, it's fine to do that. But it's wrong to do that and think we're treating a medical condition. We don't know the cause. If we don't know the cause, we can't treat the cause. We understand patients need a lot of TLC. Patients need something to be done. You pick the item that is least harmful, potentially can be used. Patients feel that you are doing something. You feel you're doing something. That's one story. That may alleviate stress, it may alleviate anxiety. They go home, they think, actually, at least the doctor is doing something. But you need to be honest. You need to tell the patient, I don't know the cause. I don't know whether this will help you. I will try. But you have to understand. You have to be honest with the patient. But we can't walk around and say unexplained, unexplained, and then call it idiopathic, hide the language, and then say we're giving you something because it's going to work. No, that's not right. We don't know, we say we don't know, and we say we don't know how to treat it, but we will try this or we'll try that, and we hope it will work. And then, yes, you heard from Pratima right from the start. At the end of the day, the prognosis is good. If there's I showed data, right, which talked about a 33% failure rate after 4 miscarriages. That's a 67% success rate.
Chances of success, yeah. I think in this list, my favorite is the lifestyle modification.
Actually, when it is called
because
unexplained,
it's got many other benefits other than.
Actually, when it is called unexplained, it means all investigations done, and there is nothing abnormality found. It is called unexplained.
Acceptable.
But truly, in our situation, each and every obstetrician, they cannot say that they don't use progesterone because actually we cannot identify unexplained.
Yeah. Okay, so we'll move on. I think the progesterone debate continues. So, well, now I'm going to come to the prognosis. Prognosis, we need to understand the prognosis of recurrent pregnancy losses generally is quite good, and but there is a, yeah, I'm almost done. Yeah, I'm just going with my time there, actually. Okay, so, okay, let's summarize. So, just the gist of all that you heard, I'm just going to summarize this in the next 2 slides. More than 3 consecutive losses beyond 20 weeks, less than 20 weeks and beyond 20 weeks occurs in about 1%. The easy ones are the chromosomal anomalies in the products first, then the parents, uterine anomalies, APLA, endocrine, if there is poorly controlled diabetes, because I'm sure diabetes is a pan-Asia problem, thyroid dysfunctions, PCOS, sorry, not PCPS, hyperprolactinemia, and the risk of recurrence usually the same time. If miscarriage happens around 14-15 weeks, next loss is also around the same time. And as the pregnancy advances, the chance of having a good outcome increases with increasing gestation. Okay? So evaluation is generally after 2 or 3 consecutive miscarriages, diagnostic criteria with history, physical examination, laboratory investigations, and don't forget the male contributor. And finally, most women with RPL will have a good prognosis for eventually having a successful outcome, even when definitive diagnosis is not made and no treatment is initiated. So even in the normal versus abnormal diagnostic tests, the difference between the successful pregnancies is very little really, 77% versus 71%. And finally, what really works in my opinion is tender loving care. You know, good ultrasound, weekly scans to show them the heartbeat, build up a positive attitude, and make them believe that they can carry on the pregnancy. And I think that goes a long way. Thank you very much, panelists, and thank you very much, audience.
And thank you so much for your wonderful moderation of this exciting panel discussion. And we think that we all will be very helpful from this updated session. Okay. So now this is the time of handover of certificate of appreciation, and I would like to request our speakers, today's speakers, Professor Mahesh Chulani, ladies and gentlemen, can you give you a big hand? Thank you, madam. Now I'd like to request our legendary Professor Muhammad Rashida Begum as a panelist to take her appreciation certificate. Okay. Next, Professor Munira Firdausi, madam, please. Professor Shaheen Farhad Siddiqui, madam, please. Sorry, Professor Shaheen Farhad Siddiqui. Thank you, madam. Next, I would like to request Professor Shahi Farzana Tasmeen, Professor of OBGYN at Rangpur Medical College, and I would like to request our another chairperson, Professor Rashida Murshid madam, to Roshan Murshid madam. Our next panelist, Dr. Tanzeem Sabina Chaudhary. And the last, Dr. Tazmeera Sultana. Thank you.
Now, I would like to request our chairperson, Professor Iffatara Madam and Professor Roshan Murshid Madam to hand over our book written by our pioneer of fetal-maternal medicine, Professor Firoza Begum Madam, on high-risk pregnancy.
So I'd like to request all the panelists today and the chairpersons and the speakers, please, can you all would like to have a good picture. Thank you all the participants and thank you to the pharmaceuticals company, and I would like to hand over the mic to the next session. Thank you.
Bismillahirrahmanirrahim. Distinguished guests, ladies and gentlemen, participants from home and abroad, Assalamu alaikum. These are Dr. Mahfouz Asma
and me, Dr. Shafinaz Mehjabin,
welcoming you all in the 6th session of our 2nd International Conference of Maternal Fetal Medicine Society of Bangladesh. Our session is on omics and maternal fetal medicine, which is an attention-grabbing issue in our journey with high-risk pregnancy management. The theme of this conference is Quality Care, the Savior, with which genetic testing is very much related.
We are honored to have Professor Dr. Anisa Begum Madam from Rangpur Community Medical College Hospital, Vice President OGSB Rangpur Branch, Organizing Secretary, Central OGSB. And another chairperson is Professor Kamrunnesa Runa Madam, President OGSB Chittagong Branch, ex-Professor Chittagong Medical College Hospital. I am requesting both of them to come up the dais and take their seats. Dear audience, in this session, we have two eminent speakers from abroad. The speakers will get 20 minutes for presentation. The speakers are requested to complete their presentation in time. If anyone have any question, please ask it at the end of the session. If time permits, speakers will definitely give answers. Now, it's my great privilege to request the chairpersons to conduct the session.
Assalamu alaikum and good afternoon to all. Now we'll come to this session, Omics of Maternal Fetal Medicine. We know that human embryo experience 2 cycles of epigenetic reprogramming in their life cycle during the period of germ cell maturation and embryogenesis. If there is any toxic insult, then the epigenetic modification can start it. And we know that this epigenetic modification runs in family up to 14 generations. So we must know about this important issue. And today our speaker is Professor Dr. Mondakini Pradhan, Professor and Head, Department of Maternal and Reproductive Health, Sanjay Gandhi Postgraduate Institute of Medical Science, special interest on areas of genetics. Now I am requesting Professor Mondakini to present her speech.
Good afternoon, good evening. Thank you, Chairpersons, and thank you, Professor Firoza Begum. I'll rush through my slides and hopefully I'll finish on time. I have this, if you listen about genetics, genetic diseases, genetic counseling, genetic sonogram, all these genetics, your reaction will be something like this. Either you will run out of these halls, and there are so many exits from this hall. See, these people are running out of it. So, or those who are sleeping will start snoring. Those who are snoring will start dreaming. And definitely they will dream about genetics probably. Okay, so we have got this background knowledge that every cell has got 46 chromosomes, and these chromosomes are nothing but they are double helical DNA structure, and they have this ATGC. These are the basic structural unit, and 3 of them forms a codon which codes for an amino acids. And with this, and every cell has got 46 chromosomes, 44 autosomes and 2 sex chromosomes, which are different. And my next few slides will be explaining you what is genetics. At least, if you, after this conference, at least you should have the basic knowledge. What are these genetic tests? People start talking about product of conception, karyotype, parental karyotype. So I will explain all these with these depiction of book rack, and then these lines making books. So all of us know that letters makes lines, few lines make pages, pages make a book. Madam has written such a nice book and she has got this experience of this. So these books are kept onto racks, and these racks are put onto a library saying that this is pathology, microbiology and obstetrics gynae. You straight away go to my obstetrics gynae rack and look for a book of obstetrics gynae. Yes. So I will depict it in this diagram. So alphabets makes words, words makes lines, lines make page, and page makes a book and then a book rack. So now these alphabets are nothing but in genetic sense these are ATGC. These are the basic unit of a gene. They form codon. Each codon codes for one amino acid. Multiple amino acids forms a protein, or in other words multiple codon forms a gene. There are multiple genes in one chromosome. So when we talk about chromosome 1, we talk about many genes in chromosome 1. So, and do they look like the way we get a report? Arranged as 1, 2, 3, 4? No. Under a microscope, the chromosomes look like this. And to depict it, what I have done is all those 46 chromosomes have been arranged like this. You can't make out anything. And in a test, we arrange them onto 1, 2, and in pairs, and so on and so forth to form whether it is XX or XY. So this is how the chromosome testing are done. So arranging the book rack in a library is nothing but doing a karyotype and then identifying them as 1, 2, 3, 4 and 23 pairs. So now if you get one extra chromosome 21, that is nothing but trisomy 21, or in other words, you all, since morning you are listening about fetal aneuploidy screening, this is what is trisomy 21, or one extra chromosome of chromosome 21. So the total number of chromosomes will be 47. So 46 and plus 1, 47 chromosomes in this chromosome. Now what has happened? Some of the, say, pathology books have gone and got shifted onto obs gynae book rack. So there is translocation of some books, or what is called as a translocation. So this is what is called as a translocation between chromosome 2 and 10. And this is what we get a report in a patient of recurrent abortion, or in a couple of recurrent abortion, either in the husband or wife, we get a balanced translocation. There is no loss or gain of genetic material. Now we have done a chromosomal analysis or analysis of the book rack. We can find something missing over here, and we call it abnormality detected on karyotype or chromosomal analysis. So we can detect it. Can you detect any abnormality in this? No, you cannot detect on the karyotype. So you move on to the next test. But to be frank and sincere enough, truly there are some books missing in this rack. That is what I have made it. So once we do not see any missing book on the rack on our routine examination, we go on to looking for the page, if the page number is missing or what. So now I go and look for page number if they are missing. So 49, after that it should have been 50, or 50, this is duplication or deletion. So deletion or duplication of one page is equivalent to doing for a microarray, or microarray test does this, and you can see this abnormality in the microarray. So your chromosomal analysis is clear. Now you are entering into the chromosome and looking for the deletion duplication, that is microarray. Now your page numbers are same. So that means you are not detecting any abnormality on a microarray. So still there is some abnormality. So you do the further testing, what is called as a exome sequencing. And to make you understand, that is reading of every word is called as a sequencing. And I have taken this sentence, I want to have an omelette. So if this word omelette is replaced by toilet, so you can, yeah. So everybody is listening at least to me. And if I omit another word, so I want to have too late. Make no sense. So make either an abnormal sense or a no sense. So this is what happens if we alter one single letter or delete or replace it. And that will be picked up by doing a sequencing of the test. So now we have heard or remember these three tests: karyotype, microarray, and sequencing. And if we do whole exome sequencing, which the exomes which are the coding portion of the gene, then that is called as whole exome sequencing. These tests are readily available. The costs are drastically decreasing day by day, and we can always do that. So change in base pair, that is ATGC, replaced, deleted, duplicated, change in amino acid, and leads to change in protein. That is our basis of genetics. Now I have given this topic of also genomics, study of genes, and epigenetics. So it will go above your head. Epi means above. So going above your head is epigenetics. So let's do, and let me do justice about it. So what it means is, at the genetic level, they are normal. There is something else which is acting and changing the protein product. And so epigenetics is the study of how behavior, environment can change the expression of a gene. And change in base, there is a genetic change is, I have already explained, genetic change is change in base pair or the sequence of the gene. But epigenetic, there is no change in DNA, and these are reversible, and they can change how body reads this DNA sequence. Your DNA sequence is same, but there is something above which is acting. So let me see this. All of us know that there is fertilization, single cell that forms into zygote, then morula and blastocyst and an embryo. So this single cell with the same number of DNA, same expression of DNA, same DNA sequence forms onto a muscle cell, a nerve cell, and so many different type of cells. For example, hepatocytes. So what factors play a role? There is something above gene which is called epigenetics, and that plays a role. So epigenetics begin before birth, continues throughout life, and all cells have the same gene. That is what I was telling you. But look and act differently. So these cells have same gene, they look different, they act differently. So what is controlling is the expression of some genes are switched off, some genes are switched on. So that is this factor which controls that is called as epigenetic. So like heart cell, nerve cell, and skin cell. The most important example is, all of us know that hemoglobin F is expressed in fetal life, hemoglobin A is in adult life. A has got alpha 2, beta 2, or 2 alpha chain and 2 beta chain makes a adult hemoglobin, 2 alpha chain and 2 gamma chains make a hemoglobin F. See, the genes are located on the same chromosome on the same stretch. So the gamma are active in fetal life, which forms hemoglobin F, alpha 2, gamma 2, and beta is active in adult life, which forms alpha 2, beta 2. So there is something above beta which switch on beta and switch off beta, and there is something above gamma which switch on gamma and switch off gamma. So fetal life hemoglobin F, adult life hemoglobin A, the genes are present. This is not that genes are deleted in your life. So that is what is called as an epigenetic effect. There were study to look into study of a newborn versus 26 years versus 103 years. And what they found is the factor that determines epigenetics is different in a newborn as compared to 26 years and as compared to 103 years. So they have identified what are the factors that looks into, that does this epigenetic factor. And in smokers versus non-smokers versus former smoker, those who have left smoking have changed that it is not an permanent effect. It can be reversible. That means a smoker develops some epigenetic effect, and then if he leaves, then these epigenetic effect may be reversible. And when it gets reversible is, it depends on the duration and amount of smoking that the person did. So this is proven by different methodology. So what are the mechanisms? There are 3 mechanisms that have been elucidated. I will not go into detail, but there is first is DNA methylation. Somebody who are doing research, somebody who is interested into it can know that if a methyl group is added onto it, the genes are silenced. So the basic concept is methyl donor, or the drugs that donate, or the vitamins that donate a methyl group keeps the genes, silence the gene. So there are methylation study to know epigenetic factor. That is the first mechanism. The second mechanism is histone protein. There are modification in histone protein, which is this double helical structure is wound around proteins, and these proteins are called histone protein. And this histone modification, and there are certain non-coding RNA which silence this coding RNA. So non-coding RNA will not code for any RNA. They do not, we think that they do not have any function. But what they do is they are expressed and they go and modify this coding RNA. So these are three mechanisms of epigenetic, and all of us knew during COVID-19 that there are few patients who expressed, who were more severe than as compared to the other patients. So what happened? So there the immune system, the infection can change our immune system, and there are certain genes which were switched on, certain genes which were switched off. Like Mycobacterium tuberculosis, the switching off of this gene led to severe disease manifestation. These are from different study that has been done and has been proven. So this infection now acted as a epigenetic factor, expressing the gene and modification of manifestation of a disease like as simple as tuberculosis. So cancer, there are certain mutation and certain DNA methylation which makes the patient prone for a cancer. Like colorectal cancer, what they do is they collect the stool, then they isolate DNA and study DNA methylation. Depending on the methylated DNA, they classify the patient into high risk for colorectal cancer and low risk. And those who are high risk are subjected for colonoscopy. Those who are low risk are not subjected for colonoscopy. So say 5 years down the line, probably we will be listening more about epigenetic factor. Coming on to pregnancy, nutrition pregnancy, all of us know that folic acid prevents neural tube defect, and this is because of some effect that is done in those women who takes folic acid. It was proven in Dutch hunger winter famine study that occurred between 1944-45. Those children who were pregnant by that mother, after 40 years they were studied and they were found that they have got high disease rate of heart disease, schizophrenia, type 2 diabetes, as compared to their siblings who were born after or before this famine. So naturally there is something which acted for expression of this disease and make these persons more prone for their less amount of nutrition to the mother, led to this disease prone condition. There are study, I will not go about epigenetics and adult onset disease, epigenetics and onset of labor. So your onset of labor is also determined by some factor. Then there are methylation, DNA methylation in endometrium, so which leads to this thing. And then gestational diabetes also. All women are not prone for gestational diabetes. That is determined by epigenetic factor. So maternal nutrition, microbiome and epigenome led on to a healthy baby and led to adult onset disease. So more of adult onset disease we are going on seeing. So there are antenatal factors and epigenetic modification in the offspring which occurs in antenatally. So mother exposed to all these things can have, like I would like to highlight that mother supplementation with hereditary methyl donor like folic acid, vitamin B12, choline, zinc, methionine and bacteria have increased risk of allergic airway disease in the offspring. So these are things that are coming up. So that is about genes, genetics and epigenetics. What I talked about is there are certain genetic tests, and as an obstetrician we should know karyotype, microarray and exome sequencing. And the epigenetic factor, we know that there are something above genes which modify the expression of genes. Probably that will suffice. So after this lecture, you think you have wasted some 15-20 minutes. or you are happy, you know about karyotype, microarray and whole exome sequencing. You will think that would like to know more in future. This is beginning. Or somebody is nodding their head, probably she is agreeing to this. Genetics is going to change our OBGY practice in future, and you are very sad. Everything has gone above your head. So you have probably wasted, or you had a good time coming to this conference and had good chobi. So thank you so much, and thank you, madam, for this thing. You fit yourself into one of them. So thank you so much, and thank you all for waiting for this lecture. Thank you. Microphone काम ना कर. You can come here. Come to the dais. Madam, please come to the dais. It's from there. Yeah.
Thank you, Professor Mandakini, for your beautiful and excellent presentation. And obviously, it is a time-demanding presentation. I was simply amazed how she delivered a hard topic into simplest way and making it very understandable. Thank you, madam. Our presenter has given a clear idea about genetics and epigenetics. I am put some comment about genetics. We know that genetics deals with gene and gene function, and epigenetics deals with gene regulation. And genetics focus on how the DNA sequence lead to changes in the cell, and epigenetics how DNA is regulated to achieve these changes. Main thing is number one, gene and gene expression. Madam rightly said that epigenetics are always changeable, reversible by some environmental factor, and we know that epigenetics, there are 3 epigenetics markers like DNA methylation, non-coding, RNA and microRNA, histone modification. These 3 are epigenetics marker, and I previously mentioned that epigenetics runs in family up to 14 generations. If we search the generation to generation, we see that there is some change similar to previous one. So more studies needed, and we are togetherly, if we work, we can learn more, and for our future generation to avoid genetics and epigenetics problem. Now I would like to conclude by thanking to all of you, all the attendants, for your vibrant participation in this webinar, and we have some keen interest. We have grown a keen interest about genetics and epigenetics. I requesting young fellow to hard work more and more regarding genetics and epigenetics, so our future generation can be benefited. Thank you for learning, patient hearing.
Good afternoon. Actually, I would like to congratulate Dr. Mandakini Pradhan because she evoked all the participants in this sleepy evening with her excellent deliberation. Thanks indeed. Now I would like to call on stage Dr. Priya Kadam. She is the Director, Reproductive Genomic Medigenum, Bangalore, India. She worked in genetics testing and cancer biology during her career in Singapore. She was involved in research in NIPT during her work at the Department of Obstetrics and Gynecology at the National University of Singapore. So she will deliver her speech on role of pre-implantation genetic testing, current scenario and future trend. So please, Dr. Priya Kadam, go ahead with your presentation, please.
Madam, we have an option. We have an option.
Okay, good evening, everyone. I'm really glad to be here. It is my second time. I'll be talking about pre-implantation genetic testing. Dr. Mandakini ma'am has really simplified this entire topic of genetics. And what I will do is actually speak about a specific application, which is in pre-implantation genetic testing. This is an image from 2018 during the first conference. And I have taken another picture, so maybe hopefully, like Prof. Mahesh said, I'd like to come again. So what is pre-implantation genetic testing? It is actually comprises a group of genetic tests which actually evaluates an embryo before it is transferred into the uterus. So previously, you might be familiar with terms known as a pre-implantation, PGS and PGD. I saw in the previous deliberation on recurrent pregnancy loss that the term PGD was used, but now what they actually mean is it is PGT-SR. So there are three classifications of pre-implantation genetic testing. Pre-implantation genetic testing for aneuploidies. Aneuploidy is chromosome number. We all know that early embryos can be aneuploid. And this PGT-A is testing for aneuploidies. PGT-M is testing for, like Prof. Mandakini said, the letters in the book. So we actually look for specific letters, that is PGT-M, those disorders which are caused by Mendelian inheritance or monogenic disorders. And structural rearrangements is like we all know about Robertsonian translocations, reciprocal translocations, inversions. We know that they have increased risk of recurrent miscarriages, and that is probably because of aneuploid embryos. So how pre-implantation genetic testing or PGT-SR can be used in these cases. So now this is an overview. Of course, to do PGT, you would need a well-established IVF center where the embryos can be generated, where the embryos can be biopsied, and the testing can be done. Now, of course, my future trends, I will talk about another method which does not actually need the biopsy, but we can use the culture medium which is used to grow the embryos for the testing. So what is the material that is used? Okay, so now this pre-implantation genetic testing is only about 30 years old. The first test was done around 1990s to actually identify gender in X-linked recessive disorders. So because the female fetuses would just be carriers or unaffected. So that was one of the earliest use of pre-implantation genetic testing. So what is the material that is used? As you can see, it can be a polar body biopsy, or it can be the day 3 embryo. In day 3 embryo, you would take about 1 to 2 cells, which is known as a cleavage stage biopsy. And what is now used is the blastocyst biopsy, which will be the trophectoderm cells, which forms the future placenta. So this can actually give a few more cells, and now please bear in mind that we actually use very small quantity of DNA to actually make the diagnosis, and therefore when you have a few more cells with the trophectoderm biopsy, which is the day 5 biopsy, you would have a better outcome and less failure rates. Now coming to pre-implantation genetic testing for aneuploidy. So why this was started was to increase the potential live birth rates and to decrease early miscarriages. So this was the assumption with which pre-implantation genetic testing was started. What was the earliest method? The earliest method of testing was just looking at the embryos under the microscope. So there were certain grading systems where you identify maybe how the cell is dividing, whether it is synchronous, asynchronous, presence of fragments, and certain other factors which graded embryos in different classification, maybe A, B, and C. And then that was the high grade embryos were used for transfer. But what was found was it did not really significantly improve the pregnancy rates or even live birth rates. And what was then found by other techniques was that if you look at this graph, you can see that even grade A embryos, which are the lowermost, have actually 32% of aneuploid embryos. So even if morphologically the embryo looks good, it is possible that 30% or 32% of them can be aneuploid. Though morphology is a very good indicator of aneuploidy, as you can see the aneuploidy rate increases with the lowering rate. You don't actually, even with high grade embryos, it can be aneuploid. So now the techniques have improved. The earliest technique, of course, was FISH. FISH was limited by looking at just a few chromosomes. You don't look at genome wide, and we know with our experience in the laboratory that there are, other than the common chromosome abnormalities, there are several others that we see the abnormality in. This was followed by multiplex PCR and then array CGH and finally NGS technique. So array CGH and NGS can actually look at all 24 chromosomes. So that was the advantage of these techniques. Right now we do the NGS based techniques. So when do you actually offer? So in an IVF center, you would want to know what are the tests of these three, which is the one which you should use, and what is the ideal indication. So the indication is advanced maternal age, recurrent pregnancy loss, repeated implantation failure, severe male factor infertility, when you want to transfer a single embryo, and when you're going to do a PGT-M. I will come to that later because you want to make sure the embryo is not aneuploid when you're looking for a single gene disorder. And of course, for carriers of balanced structural rearrangements, where you will do PGT-A or PGT-SR. And if there is a family history of genetic disorder, so you are looking at a specific family which has one abnormality, you will do a PGT-M. So now let's look at some of the data that is there for PGT-A. Now this is a bit of a controversial topic where some of the guidelines recommend it. Some of them say there isn't enough data to actually recommend PGT-A for embryo transfers, but I present some data. Now we know very well that as maternal age increases, the number of euploid means normal number of chromosomes goes on decreasing. So by 44 years of age, you would have only about say 10 to 15% of embryos which are euploid. But if you use PGT-A in these women, you would see that there is 45% delivery rate versus 19% delivery rate with no PGT. Similarly, for recurrent pregnancy loss as well, you see quite a drastic difference in the live birth rates with PGT-A samples versus non-PGT-A samples. And for repeated implantation failure as well, you see the major difference. But these are some isolated studies. There are also certain bigger trials which actually have not seen the difference, but many of these studies are also limited by how they are structured, the patients that they have identified. So what is the reason that there might be, the PGT-A is not working as promised? It could be because these are some of the assumptions which are made. Is aneuploidy the principal cause of failed implantation? Does a single biopsy which we do at such an early stage representative of the ploidy status of the embryo? And thus the percentage of aneuploid DNA in the single trophectoderm biopsy reliably determine the embryo mosaicism and also the potential for this to become a live baby. So what happens when you still decide to do a PGTA, PGTM or PGT-SR? So once the biopsy is done by an embryologist, it is a laser assisted biopsy. It has to be transported to the laboratory wherever the testing is done, and this is a dry ice shipment. So once this is done, because the amount of DNA that you get from a single cell is very low, it has to be magnified. So that is called whole genome amplification. So that is done. QCs are done at several levels, and then the testing is done and the report is issued. So if PGTA is done, there are 3 specific scenarios. The first scenario, as you can see here, you might get no aneuploidy detected. That means this embryo is recommended for transfer. As you can see in a plot here, it can be represented in different ways. So you have these chromosomes over here. In India, we don't determine sex, and therefore there is no image over here, though we say whether it's normal or not normal. So here you can see that there are 2 copies of all chromosomes, and therefore this is a normal embryo which can be recommended for transfer. Over here you see that there is a loss of chromosome 22, so this will not be recommended for transfer. This is a PGTA result. So before this, our results were binary, either we recommend or not recommend for euploid and aneuploid. But now there is actually a third category, which are mosaic embryos. So what are mosaic embryos? As you can see here in chromosome 12, there is a loss, but it is not a very serious loss. So what do you do for these embryos? Initially, people would not recommend this, but now there is more and more data coming in that mosaic embryos can be used for transfer when there is no other option. So what is mosaicism, first of all? So we know that looking at these 3 diagrams, this is completely normal trophectoderm, normal inner cell mass. Here you have a completely abnormal embryo and an inner cell mass. And over here you have a mosaic, that will be both normal and abnormal. Now what your result will depend on where you're going to biopsy. Suppose you biopsy from here, you're going to get 80% of the cells which are abnormal. So this is mosaicism, but even now there are certain guidelines which have come in of if you have a mosaic embryo, how what type of mosaic embryo can be transferred, which chromosomes it should involve, and there is also something called a low grade and a high grade mosaicism. So since we do PGTA testing in our laboratory in Bangalore, what we have seen is if the maternal age is less than 35, we have 42% of them will be euploid, about 43% would be aneuploid, and 11% mosaics. Some of them may show early failure, which is a WGA failure. And if it is more than 35, we would have about 37% which are euploid. So as such, when PGTA is offered, one of the very important aspect is counseling, because it's likely that they may not find any normal embryo, or they might find more than one. I mean, genetic counseling is a very important aspect of any kind of genetic testing. So what are the advantages of PGTA? What is believed to be the advantages of PGTA in certain conditions? It is improved live birth rates, lower miscarriage rates, fewer embryo transfers, less embryo cryopreservation, reduced time to pregnancy. And limitations, of course, with any testing, there can be false positives, there can be false negatives, there may be no embryo available for transfer, there could be technical challenges, and it may not actually improve birth rates. So now I'm coming to structural rearrangements. So this was discussed in RPL. So what are these structural rearrangements which you might test in the POC and find an abnormality, and then you might want to karyotype the parents. So this is actually a major indication for PGT. Usually it is reciprocal or Robertsonian translocations, and it helps identify chromosomes which are unbalanced very early. And arrays are more reliable than a fish-based technique because you want to look at all the chromosomes. And in this case also, the karyotype should be done of the parents to identify exactly what is the size of the translocation or inversion or any of the other structural abnormality. So if you look at this case, this is a Robertsonian translocation. If we know that gametes will be half the number of chromosomes, so normal gamete will have one chromosome 14 and one chromosome 21. So these are the gametes of a Robertsonian translocation carrier. You will see that here is one of each, here is also one of each. So these are actually balanced or normal number. Over here we have abnormal number. So when they actually fuse, you see that only these two will result in a normal fetus, while all the others will result in either a failure to implant, or it will be early miscarriage, or worse, there might be a fetus which had abnormality which might survive to term. So these are the issues with the Robertsonian translocations, and how can Pgt-SR help in these conditions? Now, I'd like to present this case. Actually, Dr. Pratima was talking about males not getting karyotyped, so this is one example. This was a 32-year-old couple with recurrent miscarriages, and the karyotyping was the first test which was ordered, and the mother was actually normal, but the father, as you can see here, there was a reciprocal translocation between chromosome 5 and chromosome 6. So a bit of chromosome 5 had gone there. So these people were actually recommended Pgt-SR. They sent 5 embryos. So 4 were high grade and 1 was low grade. And when we did Pgt-A, you can see these are images of 1 and 2. Exactly in chromosome 5 and 6, you actually see the loss and the gain. So this is actually an unbalanced chromosome. So this is for chromosome embryo 1, embryo 2, also a gain in 5 and loss in 6. 3 and 4, again loss in 5 and gain in 6. And again gain in 5 and loss in 6. And the embryo 5 actually had similar loss and gain as well as another abnormality. So unfortunately, this couple didn't have any euploid embryo available for transfer. So as you can see, even if it says, when they say high-grade embryo, it is possible that it can have a serious aneuploidy, or this is called actually a segmental loss or gain when it does not involve the whole chromosome. I'll come to the final section, which is a final type of testing, which is Pgt-M. So this is pre-implantation genetic testing for monogenic disorders. Here I've given example of Kabuki syndrome actually. So this can be used for monogenic disorders, for certain mitochondrial DNA pathogenic variants, but this is done in very few labs in the world. Exclusion testing, when you want to rule out certain conditions which might happen in adulthood, which are very serious conditions, and also HLA typing. HLA typing is to actually have another baby which can help a very seriously ill baby by a hematopoietic stem cell transplant. So this HLA typing can also be done through Pgt-M. So of course there have been various testing strategies starting from sexing to FISH to QFPCR to sequencing. And as a laboratory, there are various conditions which we have evaluated. So now with a lot more awareness, there are a lot of conditions. So even in your obstetric practice, you might actually get a couple who has an abnormal child. The child may or may not be alive, so how can they be handled? So what can be done is you can think of Pgt-M at that time. Of course, this can be evaluated with if full genetic evaluation is been done. Even if that child is not alive, the parents can be tested for carrier testing to see whether they have abnormality, especially in autosomal recessive disorders, which can then be done on the embryos. So these are some of the conditions. So so one other thing with Pgt-M, of course, it is a lot of to and fro between the lab, the clinical geneticist, the obstetrician, and the family, because the obstetrician is, or the IVF center doctor will actually be speaking to the patient, all the reports, and if this particular condition has not been evaluated, it has to be evaluated genetically. We need to know what is the type of inheritance, what is the type of abnormality. Like Dr. Pradhan said, is it like a whole chapter loss? Is it like a page loss? Is it like a single chromosome loss, a single letter loss? So we need to know that, because based on this, the test that we use, for pre-implantation genetic, for monogenic disorders will be different. So Of course, there are pros and cons of different types of testing. I'll not go into that. I'll just come into this case. So this was a 5-year-old child who was born of consanguineous parents. So in India, in certain parts of the country, we do have consanguinity, that is people marry within close relatives. We all know that the incidence of autosomal recessive disorders increases when people marry within the group, within their family. So this boy had developmental delay, ataxia, and myoclonic jerks. So MRI and skin biopsy had actually suggested that this is neuronal ceroid lipofuscinosis, and genetic testing in our laboratory actually identified a variant which is causative of that. So this was a likely pathogenic variant, and since it's an autosomal recessive lysosomal storage disorder, the parents were also evaluated. As you can see, the father and the mother both were heterozygous carriers of this condition. That means their chance of having a next baby with the same disorder was 25%, and chance of having carrier babies was 50%. So then they opted to go in for pre-implantation genetic testing for monogenic disorders. So pre-implantation genetic testing requires pre-Pgt testing, where we actually dilute the DNA of the parents to the level of the embryos, because these are all bespoke or customized tests to actually see whether this particular primers will, or the testing will work in this particular family. So it showed that it worked. So they had 5 embryos. Now, when you are doing PGT-M, it is very important to do PGT-A as well. That means you want to make sure the embryos that you want to transfer are not aneuploid, right? So this actually had 5 embryos. 2 of them were euploid. That means they had normal copy number. These were then recommended for further PGT-M testing. And as you can see here, one of them was a normal. This is a Sanger sequencing, and one of them was a carrier. So based on this testing also, the lab will be able to tell you what is the priority of embryo transfer, which is the best embryo for transfer, and then a lowering order of priority. So they transferred this first one, and that actually then resulted in a healthy baby. So there are many such cases from our laboratory. So now what is new in pre-implantation genetic testing? There is non-invasive PGT. So this is similar to NIPT, where we look at cell-free DNA. So the cell-free DNA comes from the medium in which the embryo is cultured, or it can come from the blastocele fluid. Okay, so these are the two places where actually the DNA from the growing embryo is shed. So I'll just come to this. There are some recent studies which have shown concordance between the cell-free DNA testing of the NIPGT as well as the trophectoderm biopsy. The results are okay. The maximum are about 88%. And what are the advantages of this is, like, you don't need a trained embryologist, you don't need a laser to do the biopsy. So it is non-invasive, it is safe, easy, all embryos can be assessed, and now some studies recommend that the cell-free DNA actually represents the inner cell mass more than the trophectoderm biopsy. So it is truly representative of the embryo. And what are the disadvantages? Like, you can, any kind of genetic testing which you do, like invasive testing like CVS, you might have maternal cell contamination. So that is one of the issues here. The other new thing is pre-implantation genetic testing for polygenic disorders. So that can be like for PRS scores, that is polygenic risk scores, which we have now developed for cancers, for hypertension. So these are the scores which can be done in an early embryo stage. So I'm coming to the conclusion. For any kind of genetic testing, pre and post-test counseling is extremely important, because the pros and cons of testing, what is the test, what is the kind of result that you'll get, is very important. And for PGT-A, the jury is still out whether it's beneficial or not. PGT-M, definitely there is a place for it, and it is extremely useful in families who have babies with genetic disorders or have lost babies with genetic disorders. PGT-SR, of course, is very useful in RPL and the early implantation failure cases. Despite doing PGT, all guidelines actually recommend that prenatal testing has to be done. Even if you have done a PGT, this is just to make sure that the fetus is normal and is free of the conditions we have tested for. Of course, there are several ethical considerations in this kind of testing, and that is a scope for another talk. Thank you so much.
Thank you for your Priya Kadam, for your excellent deliberation. At the end of the day, so tough subject you have described nicely. Actually, we know that embryo having abnormal genetics, transfer will be unsuccessful. So your presentation shows light to that woman who has abnormal baby in their house or at herself. So who are interested in IVF, especially, they should practice pre-implantation genetic testing for successful IVF or successful embryo transfer. So thank you very much. Thank you. Thanks indeed.
We are now at the end of the session. Now, I would like to request the chairperson to hand over appreciation certificate to the speakers. Professor Anisa Begum to Dr. Mandakini Pradhan and Professor Kamrunisa Runa to Dr. Priya Kadam. And Professor Kamrunisa Runa to Dr. Priya Kadam. Now, I would like to request the chairperson to give book to one another on high-risk pregnancy for postgraduate, written by Professor Firoza Begum Madam.
Our session is ended here. Now it is the time for evening snacks. Our inauguration and book opening ceremony will start at 7:30 p.m.